Hello. Good afternoon, everybody. Can you all hear me? Can you all hear me?
Yes, ma'am, we can hear.
All right. So, shall I start my lecture now? Are you all ready?
Yes, ma'am, we can hear.
Okay. Okay. Yeah, you have to excuse me because
Yes,
I'm
ma'am.
quite amateur to this technology. So if there are any issues, please give me a feedback. Okay. Okay.
Okay, madam.
Okay. Right. So let's start our
Madam.
presentation on drugs in anesthesia. Now, as anesthetists, we are the people who use a lot of drugs in anesthesia as well as intensive care and pain management. You know, our college is not only anesthesia, but it is intensive care and pain management. So we use a lot of drugs, and almost all the drugs we use are given through the parenteral route than the enteral route, like in wards. So I will tell you about the drugs as well as how we have to be safely using these parenteral drugs, right? Okay, so let's start off with general anesthesia. And when it comes to general anesthesia, we have certain episodes where we use drugs. One is when we use in pre-medication, and then the second episode where we have to, or the second situation we have to use drugs is during induction, and the third where we are going to maintain the anesthetic, and fourth where we are going to recover from the anesthetic. So if we take general anesthesia, what are the pre-medicants that we can use in anesthesia? What do you mean by pre-medication? We try to optimize the patient prior to anesthesia to have a very smooth sailing anesthetic. You know, when anesthesia is compared to flying. Why do we compare anesthesia to flying? When you take off in a plane, if you have jerks, do you like it? No, you don't like it. You like a very smooth sailing takeoff, correct? And same goes for a smooth sailing landing. It's just like that in anesthesia. So your induction or your takeoff should be very smooth, or your landing or the recovery should be very smooth. That is where the physiology is not disturbed in a patient. So for that, for the takeoff to be very smooth, we give the pre-medication. Now, for the pre-medication to be ordered or to understand what we should give, we do the preoperative assessment. So when you all come for my appointment, I try to tell you all as house officers how to assess a patient, how to find the problems of the patient, and how to optimize them and do the pre-medication to have a smooth sailing anesthetic in that patient. Right? So let's talk about the pre-medicants. Now, the pre-medicants that we are using have it's easy to remember if you think about it with all A's. Now, anxiolytics, most of the patients who come to us are very anxious. Why? Because they wouldn't understand what is happening to them, because it may be their first experience, or it may be their second or third experience, but still they have forgotten their first and the second experience. So that make them anxious. So the anxiolytics are the drugs that calm them down. So we can give them the anxiolytics orally with a tablet, or else we can give it to them as a injection. Whichever the way they will, we can calm them down, right? So that's one group that we use. And the second group is antacids. What do you mean by antacids? Now we have to keep them fasting for about 6 hours, and sometimes they go on fasting more than 6 hours because the surgery will be delayed and there will be other patients being done. So towards the end of the day only they will get the surgery done. So they may be fasting for many hours. So what will happen to the stomach? You have a lot of juices secreted, stomach enzymes, then uh, HCl, various electrolytes that can harm the stomach. So it is very important that you give an antacid where you can reduce the secretions, and also you can reduce the pH of those secretions with these drugs, right? So we have loads of antacids in that we use. So we'll talk about it later. Then there are patients who come with vomiting due to certain conditions. They can have vomiting. So you have to, if a person is vomiting, that person is not settled, very anxious, might be having, loads of complaints also. So that is why an antiemetic can be used to, stop their emesis and calm them down. Then people come with pain. Now if they have a wound, to go for wound toilet or suturing, they are in pain. So you have to, liaise the anxiety, analgesic effect is very important to reduce their pain. So analgesics are also part of. Hello, can you hear me? Hello, can you hear me? I need a feedback.
Yes, ma'am, we can hear.
Yeah, okay. So analgesics are also a group of drugs that we are using in pre-medication. What about antihypertensives? Now we are a population where we are aging, and a lot of patients come over 65 years for various types of surgery. And actually, you get more surgeries when you're getting older, right? With trauma, fallen from various places, then you get bowel obstruction, you get various other issues. So elderly population come to us. So they are with a lot of drugs. One of the very frequent drugs that we encounter in these patients are one group is that they are on antihypertensives, right? So we should know what to do with them. Some antihypertensives we have to stop, some antihypertensives we have to continue. Otherwise, by the time they come to the theater, their pressures will shoot up and we can't anesthetize them. So antihypertensives is another group of drugs that we are using in pre-medication. Then hypoglycemics. Now, actually, anti-hypoglycemics, I have put it that way because for you to have an A on for the sugar lowering drugs. So the drugs that are used in diabetes are called anti-hypoglycemics. It's not actually a very frequent term that we use, but I wanted everything to be starting with A for you all to remember. So that is also a drug that we stop when they are fasting, because if you continue the drug, you might end up with a hypoglycemic episode during surgery. So some of the oral drugs that we use in these patients we stop, but some of the drugs we continue, like insulin, because if their sugar levels are high, even during the fasting period, we may have to go for a short-acting parenteral way of giving these drugs and controlling the sugar level, right? So those are the drugs that we use very frequently, but we use cholinergics also. Why do we use that? To reduce the amount of secretions that that is produced in the airway. Why is it important? Actually, it is important in patients who come for awake fiber optic intubation and for various types of other intubation. Then antihistamine drugs are used for allergic patients. So let's take so I have now described the groups and why we use them. Let's see what are the types of drugs we have as anxiolytics and in all the other groups. So anxiolytics, we can group them to benzodiazepines, phenothiazines, and butyrophenols, right? So I think you have heard about the benzodiazepines like diazepam, midazolam, lorazepam, and temazepam. And all these drugs are also used not only to go for anxiolysis, but also to control fits, then to sedate them. So it has many other effects also, and you can use them as an anxiolytic as well. Then butyrophenols like droperidol and haloperidol can be used. Then phenothiazines like chlorpromazine is used in pediatric patients, which we call Phenergan. So these are drugs that can ease the anxiety and make them a little sleepy also, which is quite good to start off an anesthetic. So the benzodiazepines have other uses, as I said, sedation, anticonvulsant effect. It can be used as an anesthetic agent because it is very cardiovascularly stable. It doesn't drop the pressures like our other induction agents. And it can be used as a premedicated for anxiolysis and treat insomnia. Sometimes, elderly people take a diazepam or a midazolam tablet when they can't go to sleep or involuntary. So these are the things that the uses of benzodiazepines, and but we have problems with that if you do it too much or give it too much. Long duration of use can give, they can get addicted, and they can go into respiratory depression if you give it too much. And some of the benzodiazepines like diazepam, when you give it IV, they can end up with thrombophlebitis. If you see the diazepam, it is like oil. So when you give it into the vein, it can give rise to thrombophlebitis. So that's about it. We use diazepam, now midazolam, and lorazepam, and sometimes clonazepam. Clonazepam is mainly used to control fits. Then comes our next group, antacids. So sodium citrate is a liquid that we use in pregnant mothers or in patients who are having full stomach. What do you mean by full stomach? Where they can't evacuate the stomach contents. Pregnant mothers, they can't do it because their gravid uterus is pushing the stomach horizontal, so they have trouble evacuating their content out. And some people have bowel obstruction or some other issue where they can't get the gut mortality right. So these people retain a lot of content in the stomach. So when we give the anesthetic agent and when we stop their very important reflexes like the airway reflexes, gag, cough kind of thing, they can aspirate. So that's very dangerous. So that is why we want these antacids to go in and neutralize the stomach content, and sometimes to stop them secreting, and the amount of residual content in the stomach should be less when they come for anesthesia. So sodium citrate is a drug that neutralizes stomach content. H2 receptor blockers are drugs that will reduce the secretion of stomach contents, right? So we have cimetidine, ranitidine, famotidine, all these drugs we use in pregnant mothers, in trauma patients who are not fasting, and also in patients who have bowel obstruction or any kind of obstruction where their stomach is having a residual content. Then about antiemetics. So anybody who will vomit or who has a tendency of vomiting, you can use that. So chlorpromazine is used very frequently. That is Phenergan. Why did I say a tendency of vomiting? When you give opioids like morphine, fentanyl, and pethidine, it has a side effect where they vomit. So you can cover that side effect by giving chlorpromazine or Phenergan. So that's very useful. And also you have patients who can have the tendency to vomit due to their surgical pathology like cholecystitis or bowel obstruction or ear surgery sometimes, right? So these are the drugs that we use for anti-emesis or to stop vomiting: domperidone, metoclopramide, cyclizine, ondansetron, and granisetron. So out of these drugs, right now we use ondansetron very much. Practically all the patients who go for anesthesia get ondansetron. Metoclopramide also they get if we can't control the vomiting with ondansetron. And pregnant mothers get metoclopramide mostly. Domperidone is given for pediatric patients. Chlorpromazine is given for pediatric patients. And cyclizine is used in other countries, but in our country we don't have it. So that's why we don't use it, but it's also good antiemetic. All right. Then comes your analgesics. Analgesics, do you see my slides? Hello? Hello, I need a feedback.
Yes, ma'am, we can see.
You can see my slides. So great, right. Now, analgesics, right. Now the analgesics, we can categorize them to mild, moderate, and strong analgesics. Analgesics are very important. Why? Because we can give them pain relief pre-operatively. Say a patient comes with trauma, polytrauma, after a road traffic accident, that patient is in pain. You can have a patient who comes to the ward with abdominal pain or chest pain, whatever. The most important thing is to liaise pain, because it's humanly unacceptable if you don't liaise pain. So first thing is for you to get rid of the pain, and these drugs are the drugs that matter for you to do so, right? So pre-operatively we use analgesics if they have pain. Intraoperatively we have to use analgesics because we are inflicting an injury. The surgeons are definitely going to put the scalpel, inflict an injury. I know it is for the good, but it is an injury. So when you have the injury, at that point the pain is very severe. After the injury, the pain becomes less, but at the moment of the injury, the pain is very, very severe. So you have to use a very strong analgesic for during intraoperative period. Post-operative period, after the injury, it may not be the same, but for the first 24 hours, the pain is very much, but later it goes down, it subsides slowly. So we have to think about how to take off this pain, and it is said that if you use these analgesics not as one but as a group, We call it multimodal analgesia, where we use not one analgesic, two, three, because it has different effects. You use two or three in combination, you can reduce the pain very well. So that is what we do right now. And analgesics can be divided into mild, moderate, severe, or strong analgesics. And mild ones are used when the pain is mild. Moderate ones are used, mild and moderate can be actually used together in the post-operative period. But strong ones are used in the post-operative period as well as the pre-operative period if the pain is very severe, or the strong ones are invariably used during the intraoperative period, right? So let's see what these analgesics are. Mild ones are paracetamol and NSAIDs. Okay, so you know what paracetamol is. Even for a headache, we take paracetamol, and that's the drug that we use very frequently. Now we get paracetamol. Not you all know that we have tablets which we use very frequently, but we have suppositories also, paracetamol. So during surgery we can use paracetamol suppositories. We use that for kids quite often, and now we use it for adults also because we get a lot. We get IV paracetamol now. So intraoperatively, while we are doing the surgery also, now we can use the paracetamol. So that's a very good drug which has less complications, but you have to make sure that you don't exceed their dose, which is 20 milligram per kg per dose, right? Then we get NSAIDs, which is diclofenac sodium is the commonest that we use, but we have celecoxib, rifacoxib, all these drugs that have come up now are NSAIDs, which and ketorolac, all these are non-steroidal anti-inflammatory drugs which we can use as analgesics. So these are mild analgesics, but on top of, while you're giving them, you can use add-on a moderate or a strong analgesic if the patient's pain has not gone off, right? So tramadol is a 5-HT receptor blocker. It can be also used. It's called the moderate analgesic, where you can give it to anybody. But the problem is with tramadol is that when you give tramadol, they can vomit. So you have to time that drug properly. 30 minutes before you give an antiemetic and then you give the tramadol, no vomiting. So that's how it goes, right? Strong analgesics are morphine, pethidine, and fentanyl, and very weak analgesic is codeine. Right? These drugs are used intraoperatively as well as postoperatively, but we use it in pre-op period also. Sometimes if you have a patient who is having severe pain. Now you have to remember one thing with NSAIDs. You can't give it to patients who have renal problems or gut bleeding. Remember that, because try to avoid NSAIDs in patients who are elderly because they have renal issues. They are more or less CKD patients, so be careful when you're giving NSAIDs. Right. Then about strong analgesics. So these are the problems with the analgesics. Strong analgesics, so tramadol, nausea, vomiting, and sedation. Paracetamol, if you overdose, poisoning. NSAIDs, GI bleeding, renal failure, and it can also change the clotting, give rise to clotting abnormalities. Opioids are the ones that you have to be very careful about. Sedation, respiratory depression, nausea, vomiting, euphoria, respiratory dependence, and constipation are the issues that you get with opioids. But if that is when you give it too much. Now we have got in National Hospital Kandy a pain management unit, acute pain management unit, where we use a lot of opioids in a very sparingly and way, and a very safe way. We have fentanyl patches where we use paste it on the patient's chest, and it will be giving a continuous infusion for 72 hours in major surgeries. And also we have got PCA pumps. What is PCA? Patient control analgesia, where we have a pump with a connecting tube which is connected to the cannula, but that pump gives you a small infusion which is not going to give rise to problems. But if the patient's pain is not controlled, he can press on a button. So when he presses the button, there will be a dose going into the patient, and it will work. And if it doesn't work, if the patient is still in pain, the patient can press again. So he can press 5 times per hour, but he can't go on pressing one after the other because he can get overdose. So we have given a lockout interval of 10 minutes. So after one press, there's a lockout where he has to wait until that drug dose works, and then he can press again. Like that, he can press again. And if he's not in pain, he don't have to press. So he's not getting overdosed. So that is called PCA pump, patient control analgesia pump. So we use those to control pain. So we have gone on, lot of methods of delivery as well as a lot of types of drugs that we use in analgesia. If there are any questions, you can ask me. Okay, you can stop me and ask me. Okay, can I get a feedback?
Okay, madam.
All right. Okay, right. Then anticholinergics are the drugs that I said are reducing the secretions, right? So glycopyrrolate is a drug that we use very frequently for this purpose, but atropine and hyoscine also can be used. So when do we use these drugs? Now say we have a patient who has a very difficult airway, mouth can't be open, he has a growth in his larynx. Now we can't, if we go and put him to sleep and paralyze him, we are going to get into trouble to put the tube. That's what we fear most as anesthetists. So what we do is we give a local anesthetic and numb their airway and put a fiber optic bronchoscope and put the tube along with that. So when you're doing that, you don't need a lot of secretions there because you can't see with the fiber optic bronchoscope where you're going, what the structures are and all that. So you need reduced secretions, and in that context, this is a drug that will help you to reduce the amount of secretions that is produced in the stomach, the mouth, right, and the airway. So this is very helpful for fiber optic awake intubations, right? All right. What are the side effects of anticholinergics? Tachycardia, the heart rate goes up, dryness of the mouth, and when children, if they have fever, if you give that, their fever goes up because they can't sweat or reduce their temperature by evaporation. So that is why they say don't give it to children, right? Okay, so now we have finished the pre-operative or the drugs that we are supposed to give during pre-op assessment to optimize their patient, your patient and ease anxiety. Antihypertensives, the diabetic drugs, and asthmatic drugs, most of them should be continued, except for the diabetic drugs. You have to, consider the duration of action. If they are fasting and the duration of action is long, then you have to stop. Otherwise, it's not necessary to stop. Then comes your, you have to actually take each drug separately and decide whether to continue or with the patient's sugar level. You have to decide whether to continue or discontinue those drugs, right? Then comes your asthmatic drugs. All those should be continued because the drugs that we are going to introduce to their airway may be very irritant. So there are asthmatic patients who are having a very reactive airway. Definitely they will get bronchospasm. So you have to be very, very careful about it. So let's talk about the gases that we give in anesthesia. What are the gases we give? We have to give oxygen, otherwise they'll die. So we give oxygen. Then why are we giving nitrous oxide and air? Nitrous oxide doesn't do anything to us. Why should we give that? Or air? Air has nitrogen 80% and oxygen 20%. The reason why we give air is because of the nitrogen. Why? Because if you give 100% oxygen without giving any other gas, all the oxygen will be absorbed into the circulation and the alveoli will collapse, which is not right. You will get lung telectasis, and that can close up the airways, right? And the alveoli. So that is the reason why we have to supplement with another gas like nitrous oxide and air, right? So that is why we are supposed to go for these gases, right? Let's take oxygen. Now, oxygen is a drug. We all forget that when we give oxygen, and we give in very high concentrations. And when you give in high concentrations, it is toxic. So you have to always remember it's a drug. Don't give too much and don't give too little, right? Then comes your low concentrations definitely to cause hypoxia. High concentrations, it can cause lung fibrosis, changes in the eye, and changes in other systems, right? How do we give oxygen? Now, oxygen is the ion in air, but it's in 20%, but we have to give it more. That is why we have to give it in a system. There are two systems that we can deliver oxygen. One system is the cylinder. Other system is the pipeline. So when you come to do our anesthesia appointment, we show you the cylinders and the pipeline, right? And the cylinders are colored as a white shoulder and a black body, and the pipeline is colored as white, so that we don't mix those air, the types of air, because otherwise you think that you're giving oxygen, and if you give something else, you're going to kill the patient. So it's very important that you have the color code and you don't mix them up, right? So support problem is it supports combustion. So you have to be very careful. You can't have matches, matchsticks igniting, anything igniting, it will start exploding or you can get into a fire. So you have to be very careful when you are using it, right? And also maintains, when you give oxygen, you are supposed to maintain a partial pressure of 100 millimeters mercury in blood, so that the patient is going to have enough oxygen to utilize for the tissue functions, right? Now, this is a cylinder where you have a black body and a white shoulder. And this actually, once I gave as a question for you all, for the medical students, to name this picture. Now, this is actually a way that we give oxygen in wards. When a patient needs oxygen, we give in a cylinder, and it has a flow meter. It has a water bath where you humidify this dry oxygen, and it goes through this tubing into the mask, and the patient can breathe from that. So this is a very simple way of giving oxygen to a patient in a ward. So when you become house officers, you're supposed to give oxygen if the patient needs oxygen through this kind of a device. So that question was where I asked to label this diagram, where you should know this is the flow meter, this is the water bath, this is the delivery system, the mask and all that, and this is your cylinder, which has a white shoulder and a black body. Okay, and this is your pressure regulator, because this cylinder has stored oxygen in a very high pressure. It is 132 bars. Our atmospheric pressure is only 1 bar, so it is 132 times high. So if you it has to reduce the pressure and come to the patient, otherwise the lungs can go off. Right. So the nitrous oxide cylinder is blue color. We call it French blue. And nitrous oxide, when you pressurize nitrous oxide gas, it becomes liquid. And it stays as liquid. Half of the cylinder is full of liquid. The other half is doing the gas which is evaporated from the liquid form. So the gases go out and the liquid gets evaporated, and at the end of the day you don't get any liquid, and all converts into nitrous oxide and it gets utilized through the system. So nitrous oxide is a drug that we use as an anesthetic. It has a tiny anesthesia effect, but it has an analgesia effect mostly, and we use it for labor pain and dental surgeries. We use nitrous oxide, but it can cause certain adverse effects, nausea, vomiting, and in fetus, it suppresses red blood cell formation, and sometimes it's said, but it's not proven, that it can cause abortions. So that is why we now don't use nitrous oxide much. We try to use air instead of nitrous oxide with the oxygen when we give anesthesia. But still it is used as Entonox. Entonox means oxygen nitrous oxide mixture, which is given to patients who are in labor pain. So it supports combustion, and you have to keep that in mind. So the IV induction agents that we use are, now these are drugs that we use to supplement anesthesia, the gases. To induce a patient or to put them to sleep, we need a strong agent. So IV induction agents are the ones that we use to quickly put them to sleep, and thiopentone, propofol, ketamine, and etomidate are drugs that we use. So thiopentone, it is a powder that comes, and we put water and make it a straw color solution, and that is what we are going to inject, and it has to be at a concentration of 5%, otherwise it will irritate the veins. So we have to be careful of the concentration. Then it makes the patient unconscious, that is what we want, but it doesn't have any analgesic effect. Good thing about it is it's given to in brain injury patients or head injury patients or any patient who has a head problem, because it has a nice oxygen supply demand to balance in the brain. So it doesn't harm the brain. So we like thiopentone to be given it to patients who have brain issues, right? But it has bad issues also, right? The bad thing is that it causes myocardial depression. It can cause the respiratory center to stop breathing, and if it reduces the laryngeal reflexes, and it can cause bronchospasm, and it also causes nausea, vomiting. So bad things are more. So we have, only for brain issues we use this now, but now we use propofol more than thiopentone because of these issues. And when you anesthetize a patient, they come very slowly out of anesthesia. Their hangover effect is more with thiopentone. Propofol is a white color solution. It has many things like egg lecithin, soybean oil, and all that. So when you give it to them, it is painful. So you have to be very pain on injection is what they will react when we give. So we have to be very careful when you're giving it. You have to cover it with lignocaine or something so that they won't get the pain. Color is white. It also causes sleep, anesthesia, unconsciousness, but it has a quick recovery. It dilates the vessels, so you can get hypotension, causes respiratory depression, but it does not. It does depress the laryngeal reflexes, not to the extent of thiopentone. So it's good to be used for laryngeal mask insertion. GI prevents nausea, vomiting, and it's a good thing because it has antiemetic effects. So these are the drugs, propofol, thiopentone, and some of the anesthetic drugs we will walk through in our presentation. Ketamine is a drug colorless solution, but if you keep it in a white color bottle, it can get destroyed. That is why it's in a brown color bottle, because it can have ultraviolet light can destroy the drug constituents. So that's why it's in a brown color bottle. And it's stored in the fridge at a certain temperature. It causes anesthesia, analgesia, hallucinations, and convulsions. So you have to be careful when you're giving it to a fitting patient. You're supposed to give to a fitting patient. Tachycardia and hypertension is something that it does. So if you have a patient whose blood pressure is low, good to give. But if you have a patient who has cardiac problems, it's not good to give. Respiratory depression is a condition that will occur, but they dilate the bronchioli, so it's good for the bronchial asthmatics actually. It causes nausea, vomiting, and it can cause muscle rigidity. So these are the induction agents that we use. And now when we make them unconscious, next thing we want is, if we want to put a tube, intubate the patient, we want them to relax. So suxamethonium is the drug which we call as a depolarizing muscle relaxant, which we use especially for non-fasting patients, full stomach patients. Other drugs that we use are atracurium, vecuronium, ropuronium, pampuronium. These are non-depolarizing muscle relaxants. So suxamethonium is a depolarizing muscle relaxant, and the other drugs are non-depolarizing muscle relaxants. Good thing about suxamethonium is they have not found a drug which is good as suxamethonium, which can paralyze them within 30 seconds and recover them within 5 minutes. So quick paralysis and quick recovery is very important in patients who are full stomach and who have difficult airways, right? So it is a good drug. Still, we use it because of those reasons, and it gives you a very nice relaxation where you can intubate the patient without trouble. But it has bad effects. It has 10 bad effects. I've given some. Muscle pain because of the fasciculations that happen, muscle pain. Then hypokalemia because of muscle contraction, the potassium goes up. It increases intracranial pressure, intragastric pressure, and intraocular pressure. Bradycardia is a common condition that happens with the second dose of suxamethonium. Malignant hyperthermia, it can precipitate with suxamethonium. Scoline apnea means some of the patients who have a hereditary problem with their enzyme that breaks down suxamethonium, they can have more than 5 minutes to recover. So depending on their condition, it can be 5 minutes, 20 minutes, 1 hour, 2 hours, or even 24 hours for them to recover from suxamethonium. So that is only in some patients, right? And that we call it scoline apnea. Then they can cause anaphylaxis, which will give rise to bronchospasm also. Right. Then the non-repolarizing muscle relaxant, they are slow to onset, but they have a long action. So sometimes it's very bothersome when we have a patient who is having a difficult airway because it acts long, they won't recover, so we have no way of looking after their airway. So you have to be very careful when you're giving this non-repolarizing muscle relaxant. Slow onset is not good when you have a full stomach patient, because we want them not to be ventilated. They have to quickly get paralyzed so that we can quickly get on with our intubation. So these drugs cannot, should be considered using very carefully in certain situations. Cardiovascular system hypotension is something that happens in some of these drugs. Respiratory muscle paralysis is what we want from them, so that happens. Hepatic metabolism and renal excretion is another entity that that is how they actually go out of the body, but because of that you can't, I mean, you have to be very careful when you give in liver failure and renal failure patients. Residual effects of relaxation will be there in some patients, so you have to reverse them with another drug to get their breathing back. So atracurium is a non-depolarizing muscle relaxant. I think this, of course, you will see in the books also. So I don't want to go into detail. But one thing that I want you to remember is atracurium is a drug that metabolizes spontaneously with an enzyme. So it's very, it doesn't go through the liver or liver, and the metabolites are excreted through the kidney. So it's good for renal failure, liver failure patients. Anaphylactic reaction is common. It can produce histamine release, so you have to be very careful in atopic patients. Vecuronium is a non-depolarizing muscle relaxant. It comes as a powder, so you have to make it to a solution and then give it. It is very cardiovascular stable, and it has no histamine release or least histamine release. So that is why we use it in patients who are asthmatics. Metabolism through liver and excretion through kidney. So pancuronium is also the same as vecuronium, but only thing is pancuronium has produces a very high heart rate and can increase the blood pressure. It's mostly used in cardiac patients when they induce patients for cardiac surgery. Right. Then we go, let's get on with the inhalational anesthetic agents. Halothane, isoflurane, sevoflurane, desflurane, and enflurane. These are drugs that we can induce patients or make them unconscious by giving them these drugs to breathe, or sometimes if we use IV anesthetic agents and put them to sleep, we can maintain the anesthesia with these drugs. Now these drugs are colorless. Now we have a problem of identifying them, so we have given them colors, right? So halothane becomes red because of that, and it has a very pleasant smell, so you can actually get them to breathe. But the problem is it has severe respiratory cardiac depression. It vasodilates and it can cause arrhythmias. It causes respiratory depression and can cause halothane hepatitis, and it can induce malignant hyperthermia. Isoflurane is a very irritant drug. We have given the color purple for that to be identified. So with that, hypotension also is a possibility because it dilates the vessels very much. We can't give it and induce the patients or put them to sleep because it is irritant. They get cough, bronchospasm, laryngospasm. So we don't induce them with isoflurane, and it can also cause malignant hyperthermia. Sevoflurane is a very nice drug where it has a very pleasant smell. we have given the color yellow, and for children we use this, putting them to sleep. It's cardiovascular stable, but it can cause malignant hypothermia. So these are the drugs that we have discussed. Yellow, sevoflurane, isoflurane, purple, enflurane we don't use. Desflurane we will be using very soon, because now we are getting desflurane. Halothane is the red one. So we use this in vaporizers. This is a vaporizer, which is a special gadget where we pour this drug in and it is evaporated and it comes into the circulation. So halothane red, isoflurane purple, and sevoflurane blue, yellow. Right. So this is how we fill them. The drug bottle comes, and there's a special key filling system where we fill this vaporizer through that, and the key filling system cannot be changed to another key filling system because it has a special code. It won't fit. Otherwise, you will go and fill halothane to an isoflurane vaporizer. That cannot happen with this key filling system. Right. So the analgesics we use during anesthesia are morphine, pethidine, fentanyl, and also we have alfentanil, serfentanil, and codeine, which are IV agents. The reversal is where we reverse the paralytic effect, and neostigmine and prostigmine are the drugs that we use for those. So the post-op recovery period, there are things we consider. They have to be out of pain. So analgesics, starting from the mild analgesics to the strong ones we use, stepping up. And we use antiemetics during post-operative period, and we use fluids during post-operative period if they don't take orally. So the fluids I'm not going to talk about. I think you will have a special lecture on IV fluids. So the IV fluids will be addressed in that lecture. Right. So let's get on with another group, which is the local anesthetics, where you as it shows will be using this very frequently to suture a small wound, or to remove a small lump or a bump. You may have to give a bit of lignocaine and do the surgery. It's locally infiltration of lignocaine is done, and you can do a lot of small surgery. Bupivacaine also can be locally infiltrated, but it takes a longer while for it to start action, but it lasts longer. Lignocaine lasts shorter, the action. Bupivacaine action lasts longer. Levobupivacaine, propivacane, amitocaine, and bupivacaine. These 4 drugs can be used in neuraxial blocks. Neuraxial blocks are blocks that we use to block, put the drug into the subarachnoid space, epidural space, caudal space, or to go into a nerve sheath or a bundle of nerves and give this drug to numb the nerves in the body and paralyze part of the conduction of the body. So that is also called anesthesia, but it is called partial or regional anesthesia. Lignocaine, onset of action fast but short acting. Toxic dose, I think you will go through in the book, 3 milligram per kg if it is without adrenaline, but 7 milligram per kg if it's adrenaline. IV injection, you have to be careful because it can give rise to cardiac arrhythmias. Hypotension, bradycardia, cardiac arrest can happen. High doses, respiratory depression, convulsion, and coma. Bupivacaine is another drug that we use. It has longer action, but slow to onset. Toxic dose is 2 milligram per kg. cardiac depression, and it stays, because it stays longer, the cardiac problem will also become longer. And when if a patient arrests with bupivacaine toxicity, you will not be able to resuscitate that patient for a very long time until that bupivacaine is metabolized out of the body. So that is why you should be very careful when you're giving a local anesthetic, especially bupivacaine, to aspirate and make sure that you don't put it into the a vein or an artery. So the other drug that I would like to talk about is adrenaline. This is our wonder drug in anesthesia, where if we have a cardiac arrest, this is the drug of choice, where we go for the resuscitation. And this is the drug of choice for anaphylactic shock. So you should know the doses of drug, the adrenaline, during CPR, during anaphylactic shock, and whenever the pressures drop, we use it as an inotrope, and sometimes we do use this for local infiltration to reduce bleeding also in certain surgeries. Now, now I told you, as anesthetists, we are mostly giving the drugs parenterally, not enterally. So we have to be very careful when we give the drugs, because we take it into various number of syringes, and all the syringes look the same. And if you don't have an idea which one is which, you can confuse yourself. So that is why labeling is very important. Can you see the labels? And it's color coded. I don't think you can see the colors very well. Propofol goes as yellow, emetics goes as white, morphine goes as blue, the cardiac drugs like adrenaline goes as red, and atracurium paralytic drugs go as red. So there is a color coding with these drugs also. And whenever you use these drugs, you have to label them and make sure that you know the dose of the drug when you're using them. And due to universal precautions, we don't cap the needle in these drugs. Ideally speaking, you have to cap it with these stoppers. So I think I made it a point to get my lecture completed during the period, 1 hour period. I think I have succeeded, and thank you very much for your attention.
Thank you very much, madam.
Okay.